Thank you again for joining us on this Tuesday after a holiday. Um, I'm very excited to welcome Joyce to speak today about the Maryland MOLST Forum. So, without further ado, Joyce, when you're ready, we can go ahead and get started.
Thank you, Heidi. Welcome, everyone. My name is Joyce Falkenhand, and I'm the nurse consultant for the CFP, that's the Community First program, for the Coordinating Center. Today, we're going to walk through the Maryland MOLST form and discuss what it means for you and your loved ones. This presentation is designed to make the MOLST simple and understandable, even if you've never heard of it before. By the end, you'll know what it is, why it matters, and how to use it to make sure your wishes are honored. Next slide, please. As I said, my name is Joyce Falkenhand, and I'm the nurse consultant here at TCC. I've been here for about 4 years, and I've been a registered nurse for 45 years. Next slide. Thank you. Let's go over some ground rules before we get started. Today's presentation will be recorded. However, questions and answers will not be recorded. Please remain on mute. Please use chat to submit the questions. We will be addressing them during Q&A. This is a safe space, no judgment. Participants agree not to share any personal information or opinions shared within the group outside of the discussion. Please silence your cell phone. Slides, documents, and unanswered questions will be emailed. Slide, please. Alrighty. This webinar is intended for informational purposes only and is not a substitute for professional legal or medical advice. Slide. So, objectives for us today include the following. By the end of this presentation, participants will be able to understand what the Maryland MOLST form is and why it's important. Identify who needs a MOLST and what decisions it includes. Distinguish MOLST from an advanced directive and know how to begin planning. Slide, please. So what is MOLST? We've heard this term before. It stands for Medical Orders for Life-Sustaining Treatment. It's a standardized form used throughout Maryland to document your decisions about certain medical treatments. What makes MOLST unique is that it's not just a preference form. It's actually a medical order that's signed by a clinician. That means it has to be followed across all care settings. If you're unable to speak for yourself, the MOLST becomes your voice, guiding your care team with clear, actionable instructions. Slide, please. Why MOLST matters. In a medical emergency, decisions often need to be made very quickly. Families may be overwhelmed, unsure, or even disagree about what you would want. MOLST removes that uncertainty. It makes your voice clear. It gives your healthcare team clear guidance so that they can act immediately according to your wishes. It also reduces emotional stress for your loved ones, who no longer have to guess or make difficult decisions under pressure. MOLST ensures that your care aligns with your values, even when you can't communicate them. Slide, please. So, who should have a Maryland MOLST form? Well, MOLST is especially important for people with serious or chronic illnesses or those who are medically fragile. Maryland requires it for individuals entering nursing homes, assisted living facilities, or hospice programs. Hospitals often complete one when someone is being discharged to another facility to ensure continuity of care. Even if you're not seriously ill, you may still choose to complete a MOLST if you want clear medical orders in place. It's a proactive way to make sure your wishes are honored. Slide. Advanced Directive Burst a MOLST form. You may have heard the term advanced directive before, and you may even have one in place. Both the MOLST and the advanced directive concern your healthcare decisions, but they are different. An advanced directive is a planning document. It explains your values, outlines your long-term wishes, and may name someone to speak for you if you can't. It states your care preferences for future. future hypothetical medical conditions. A MOLST is different. It contains specific medical orders that apply right now. Think of the advance directive as the why behind your decisions and the MOLST as the what to do in the moment, what to do now. The two documents work together. Having both gives you the strongest protection for ensuring your care matches your goals. Next slide, please. What the MOLST covers, and these are very specific and contained on the form. The MOLST form covers several types of life-sustaining treatments. These include CPR, breathing machines, hospital transfers, feeding tubes, IV fluids, antibiotics, dialysis, and blood transfusions. You can choose to accept or decline each treatment based on your goals and values. There's no one-size-fits-all approach. Your MOLST can be tailored to your specific situation. The goal here is to make sure the care you receive reflects what matters most to you, a reflection of your values. Next slide, please. How the MOLST is completed. A MOLST is completed with a physician, a nurse practitioner, or a physician assistant. It begins with a conversation about your health, your goals, and what you want your care to look like in different situations. Once the form is completed and signed, it becomes a medical order. Because it's a medical order, all healthcare providers must follow this. You can update it at any time. As your health or preferences change, your MOLST can change with you. Next slide, please. Where the MOLST is used. One of the strengths of the MOLST is that it travels with you. It's recognized in hospitals, rehab centers, nursing homes, assisted living facilities, hospice programs, and home care settings. EMS responders also follow it during emergencies, which is critical because they are often the first to arrive. This consistency ensures that your wishes are honored no matter where you are or who's caring for you. It creates a seamless approach to honoring your preferences across the entire healthcare system. If you move to another state, however, you will need to fill out a new document. Let's take a look at MOLST across state lines. Next slide, please. A Maryland medical orders for life-sustaining treatment, a MOLST form, is not automatically guaranteed to be valid in other states, as its recognition depends on specific state laws. While many states recognize similar documents, such as POLST, which is physician orders for life-sustaining treatment, it is recommended to complete the specific medical order form for that state where you are currently residing or receiving care. Next slide, please. Keeping your MOLST accessible. So now you have the document, but now you need to let people know that you have it. So a MOLST only works if people can find it quickly. In an emergency, time matters. Keep the original in a visible, easy to reach place. Many people keep it on the refrigerator, near their bed, or near the front door because EMS looks there. Share copies with your family, your healthcare agent, and all your medical providers. Bring it with you to appointments or hospital visits. Remember that the more accessible it is, the more effectively it can guide your care. Next slide, please. Updating or changing your MOLST. Your MOLST is not permanent. You can change it at any time if your health or preferences change. Updating it requires completing a new form with your clinician, who will then sign it to make it official. It's important to replace the old version so everyone has the most accurate information. So in the previous slide, we talked about how you need to make it accessible and have people understand and know where it is. This slide, we're saying, remember who you gave it to because they're going to need the updated slide, the updated form. Think of it as a living document, something that evolves with your needs and continues to reflect your values as your situation changes. Righty, next slide, please, Heidi. Some common misunderstandings. Okay, some people think that the MOLST is only for end of life care, but that's just not true. It's for anyone who wants clear medical orders in place. Others think it may mean refusing treatment, but that's also not true. You can choose any combination of treatments you want. MOLST is about control, making sure your care matches your values. And remember, you always have the right to change your mind and update the form. It's designed to support your choices, not to limit them. Next slide. How to start the conversation. Sometimes this can be difficult for some folks. So, talking about medical wishes can feel uncomfortable, but it's one of the most meaningful conversations you can have. Start by thinking about what matters most to you, your quality of life. You want to think about your independence, comfort, or maybe you have some other values you want to address. Share your thoughts with your family and your loved ones, and your healthcare provider so they understand your priorities. Ask questions about treatments you're unsure of. Understanding your options helps you make informed decisions and ensures your MOLST truly does reflect your values. Heidi, next slide, please. In summary, the MOLST ensures your medical wishes are honored across all healthcare settings. It provides clarity during emergencies and reduces stress for your loved ones. It's an important part of planning for your health and your future. The most important step is starting the conversation and making your wishes known. When your values are clear and documented, your care team can confidently provide the treatment that aligns with your goals. Next slide, please. Resources. If you'd like more guidance, your healthcare provider or local Maryland Health Resources can help you complete a MOLST form and understand your options. The goal here is to make sure you feel informed, supported, and confident in documenting your medical wishes. Now let's take a peek at what a MOLST form looks like as an overview. Note that the links will be in the chat and contained within the PowerPoint. Oh boy, that's small.
I'll make it bigger for you.
Thank you. Appreciate it for these old eyes. Thank you. Okay, so this is what it looks like. This is something that, remember, your physician or health clinician, physician, nurse practitioner, physician's assistant will fill out. The form includes medical orders for EMS and other medical personnel regarding CPR and other life-sustaining treatments. Okay, remember that it's valid in all health care settings and in your home as well. Okay, alrighty, so the first sections, certification for the basis of these orders starts with, as a result of the discussion with and the informed consent of the patient or the patient's healthcare agent as named in the patient's advance directive, or the patient's guardian of the person as per the authority granted by a court order, or the patient's surrogate as per the authority granted by the Healthcare Decision Act, or if the patient is a minor, the patient's legal guardian or another legally authorized adult. So this is something that the clinician, the medical clinician, is going to fill out. And you'll see that we said earlier that the advance directive and the MOLST can work together. In the second line here, the patient's healthcare agent as named in the patient's advance directive. So it's collaboration there, it's open communication. The clinician also fills out that next part. It says, or I hereby certify that these orders are based on instructions in the patient's advance directive or other legal authority in accordance with all provisions of the Healthcare Decisions Act. All supporting documentation must be contained in the patient's medical records. Okay, and then there's a line that says if the patient or authorized decision maker declines to discuss or is unable to make a decision about these treatments. The patient's or authorized decision maker's participation in the preparation of the MOLST form is always voluntary. If the patient or authorized decision maker has not limited care, except as otherwise provided by law, CPR will be attempted and other treatments will be given. So anything that was not addressed in the above section needs to be checked off down here. And keep in mind, if nothing's been checked off, then we are required by law to do CPR. Alrighty. This next section is really for the EMS providers. Okay, so in the first part of it says, attempt CPR. And that's what it means. If someone comes in, you want everything done. You want to have the CPR and everything that goes with it done. Attempt CPR, this will include any and all medical efforts that are indicated during arrest, including artificial ventilation, which is being on the breathing machine, and efforts to restore or stabilize your cardiopulmonary function. That means restore function for your heart and your lungs. Okay. If the patient or authorized decision maker does not or cannot make any selection regarding CPR status, mark this option. That reflects what we just talked about previously. Now, if you go down, it says no CPR. So the first part is yes, CPR, but down here we're looking at CPR, but there's different ways to interpret this, okay? So prior to arrest, administer all medications needed to stabilize the patient. If cardiac or pulmonary arrest occurs, do not attempt resuscitation. Allow death to occur naturally. But you'll see option A1, intubate. This means that comprehensive efforts may include intubation and artificial ventilation. That means that they're going to put a breathing tube down your throat, bag you for oxygen, and put you on a breathing machine. Option A2 is do not intubate. I don't want that tube put down my throat, but I do want comprehensive efforts made, including limited ventilatory support by CPAP or BiPAP, but do not intubate. So when you're looking at this, you can see that on one, you are actually having the tube put down your throat and you're being put on a breathing machine. Now, there are other ways to provide respiratory support that do not include the tube, but are not as effective as putting the tube down your throat would be. And that includes CPAP or BiPAP that provides some pressure to your lungs to help them inflate. Okay. And then that bottom option, no CPR, option B, palliative and supportive care. So prior to the arrest, provide passive oxygen for comfort and control any external bleeding. Passive oxygen, that includes things like the nasal cannula or maybe a breathing mask. Prior to arrest, provide medications for pain relief as needed. I want to be comfortable, but I don't want any other medications. That includes things that are needed, say, for example, to support your blood pressure. They don't want that. Do not intubate, so don't put the tube down me, or use CPAP or BiPAP. I don't want any of that other stuff on my face and in my nose. If cardiac and or pulmonary arrest occurs, do not attempt resuscitation. Allow death to occur naturally. Alrighty, let's go into the next page, Heidi. Now, that first part, as I said, was EMS. EMS comes into the home or onto the emergency scene, whatever it happens to be. Alrighty, now this part is for when you get to the hospital. This means artificial ventilation, may use intubation and artificial ventilation indefinitely, or maybe I want to put it on a therapeutic trial with a time limit. Okay. And 2C is may use only that non-invasive artificial ventilation, the CPAP or BiPAP as medically indicated, but I want a time limit on that too. And finally, 2D is do not use any artificial ventilation. Don't intubate me, don't put me on CPAP, don't put me on BiPAP. Okay, then there's blood transfusion. Remember, this is like a menu that you can choose what you want to have and not have. So blood transfusion, give me any blood product, which may include things like whole blood, packed red blood cells, plasma, platelets, anything that's medically indicated. Or don't give me any blood products. There are other options like fluids that you can be given. Hospital transfer. In some situations, okay, you may be at a community hospital, but you may need the next higher level of care. So in that situation, you're saying, yes, please transfer me to the hospital for any situation requiring hospital level care. Okay, on the opposite side of that, 4B is transfer to a hospital for severe pain or severe symptoms that cannot be controlled otherwise. And 4C says, let me be. Do not transfer me to hospital, but treat with options available outside the hospital. Okay, so this can be things like I'm in the nursing facility, I'm in an assisted living facility, I'm at home. That's what that's referring to. Okay. Medical workup may perform any medical test indicated to diagnose and or treat a medical condition. 5B is only perform those limited medical tests necessary for symptom treatment or comfort. In other words, don't get crazy with everything you want to do. I don't want all those diagnostic treatments. And 5C, do not perform any medical tests for diagnosis or treatment. Let's go down to antibiotics. Heidi, can you scoot the page up a little? That's perfect. Thank you. So 6A, I want all the antibiotics. I want this treated oral by mouth, intravenous through my IV, intramuscular into my muscle as indicated. Okay, 6B is, okay, I'll take the pills, I'll take the liquids, but I do not want to have an IV or I do not want to get shots into my muscles with antibiotics. 6C says may use oral antibiotics only when indicated for symptom relief or comfort. And 6D is do not treat my infection, do not treat with antibiotics. Alrighty. Now, 7 talks about feeding tubes, artificial nutrition. Okay. 7A says may give artificially administered fluids and nutrition, even indefinitely if medically indicated. 7B says may give artificially administered fluids and nutrition if medically indicated, but only as a trial, only for a time limit. And when they're talking about time limits, this is something you discuss with your physician or clinician. You yourself do not have to come up with that time limit on your own. 7C may give fluids for artificial hydration as a therapeutic trial, but don't give me artificially administered nutrition. 7D, do not provide artificially administered fluids or nutrition. 8 is dialysis. So when a person's kidneys stop functioning, they need to go on dialysis in order to have fluid and toxins removed from their system. So 8A says, if I need it, give me that chronic dialysis for end-stage kidney disease, if medically indicated. 8B says, may give me dialysis for a limited time period, and that time limit is. So let's try it for a little while and see how it goes. And 8C is do not provide acute or chronic dialysis. And this is signed by the physician. I think that's the end of the form. Am I right, Heidi?
Yep.
Okay.
Yeah, this.
All righty.
Yep, that's it.
Okay, so then let's go on back. There we go. Resources here, Maryland MOLST are great. These are absolutely great. The MOLST form is just the blank form that you can look over. And then this last link is MOLST form with information. See, this gives you all those options right here. I thought this was a really great site because it can give you an overview of what's needed, not only for the consumers, but for the professionals who would like a reflection on this and update. All righty. If you take us to that last slide. And questions. This is a good time to ask any questions you may have about the MOLST form or how it works in Maryland.
So we do have one question in the chat.
Excellent.
And it's can licensed social workers complete the MOLST?
I don't believe so because they were very specific about having that medical piece of it. So a licensed social worker, licensed registered nurse, we can't do that. This is only folks who have uh, a physician, a nurse practitioner who provides medical care, or a physician's assistant who provides medical care. Excellent question.
And then Terry asks, can a surrogate decision maker or healthcare agent complete the most on behalf of the patient? This is PT, I'm not sure.
It's what?
On behalf of it says patient. Yep.
Yes, yes. Let me just get to that. The answer is yes. For folks who cannot speak on their own behalf, but that would be the authorized, what's the word I'm looking for, Heidi? Author,
Guardian.
well, it's the guardian or yeah, the authorized person. Um,
This is surrogate decision maker
yes,
agent.
yes, yes,
Yeah.
yes. Thank you. I was looking for that slide. Oh my goodness. Pros and cons. That's a big one. That's a big one. That is absolutely something that you need to think about and go over with a physician because it would be really unique to that individual and their circumstances, a chronic illness and that sort of thing. Do you have specific questions about certain ones? Is there something I can make a little bit clearer for you?
And Lisa, you're welcome to unmute yourself and talk as well. Now, Kim has asked, can the MOLST form be completed by a patient, rep, etc., and signed by the provider, or does the provider have to fill it out themselves and sign?
It's my understanding that it is the physician who fills this out. Having a conversation with that client, that patient. It's not something that the patient will fill out by him or herself. You're welcome. I just know that about CPR, so I was wondering about the rest.
So Lisa was saying that some of like older patients have fragile bones,
Hmm.
and thus can often end with broken ribs and very painful. But I
Yes,
guess it's a very personal decision, again, made with your provider or physician.
absolutely, Heidi. Absolutely. And you're right. Um, in order to do effective CPR, you have to press down on that sternum, the lower third of the sternum, 2 inches, and it has to be in a certain rhythm. So, yeah, there's probably going to be broken bones for most of us, broken ribs, but that's the only way we can get effective CPR.
And I think she was inquiring about the pros and cons of the others, but I'm sure there's plenty.
Oh,
Um, whether let me get back to that form.
yeah. So it really is a reflection of your values.
Yeah.
Okay. Blood transfusions, very personal. Sometimes have a religious component to it. Um, Hospital transfer in some community areas or nursing facilities where you're receiving care, you may choose not to go to the hospital, or you may go to a hospital for the next section up level of care. So I think a lot about community hospitals in secluded areas that need a higher level of care where they do, help me out, transplants and complicated surgeries that they don't have all the facilities that in that community hospital. So that again is a discussion. Um,
And then Marianne says, I am in guardianship and have received a DNR and DNI and most completed with the clients after being declared incompetent. Is that
yes.
allowed?
Can you say that again, please?
I'm guardian in guardianship and have received DNR, DNI, most complete it with the client after being declared incompetent. Is that allowed?
So the client is incompetent and you're the guardian. Is that correct?
Yes.
Okay. Thank you, Marianne. Um, and so the DNR and DNI, was that established prior to this? Has it been established?
And Marianne, you're welcome to unmute yourself.
That would be so much easier. Thank you.
Yes, please. Hi, Marianne.
Um, yes, it was established, but it was after the medical certifications for incompetency had been completed.
So who signed for the DNR and DNI?
Medical personnel.
Okay. And that sounds like it was probably then on a MOLST form.
Correct.
Then you're all set. That that's taken off your plate since it's already been established. Did that
Okay,
answer?
but they're filling out this MOLST form with incompetent people. Are they allowed to do that?
No. I mean, it would have to be established. It can be filled out by the guardian in a conversation with the physician.
Right. As a public guardian, we do have to go through the courts, but I'm getting these MOLSTs where on the on it dated the 17th, and then on the 31st, I'm getting certification that they are incompetent.
Ooh, okay. Okay. I understand what you're saying, but if they have established it,
Okay.
then that's kind of
Okay.
what they said. Yes.
Okay.
Great question. Thank you.
And then Courtney, we'll go to Morgan. After guardianship is granted, doesn't the most revert to full code? This could be all related.
I'm sorry. Can you say that again, Heidi?
After guardianship is granted, doesn't the most revert to full code?
Not that I'm aware of.
Yes, Marianne also said no.
Yeah, thank you.
And then Lisa asked, are electronic forms allowed? Like, can I carry a JPEG or do I always need to carry the actual form?
Ooh, that's a really good question. I'll have to get back to you on that.
And I believe when I asked if someone could have it like in your phone, you said no.
Yeah, I'm thinking it has to be a hard copy. But I'd want to look that one up.
And Courtney, if you want to unmute, I'm not sure if we answered your question. If so, that's okay. I believe she said, I and two others in my office lost connection at no CPR, do not intubate. Can you go over this information?
Oh, that part there? Okay, so this part, again, this is from page 1, and this is really helpful for the EMS folks. This is what they look at. Okay, so attempt CPR, that means they're going to go in there and they're going to try and resuscitate that patient. All efforts are indicated during the arrest, including artificial ventilation and efforts to restore and stabilize the heart and lung function. Okay. The section below that, no CPR, option A. So comprehensive efforts to prevent arrest. Prior to the arrest, administer all meds needed to stabilize that patient. If cardiac and or pulmonary arrest occurs, do not attempt CPR. Allow death to occur naturally. Now, if they have checked off option A1, intubate. So, okay, I don't want you pounding on my chest, but it's okay to put the breathing tube down my throat and bag me with oxygen and put me on the breathing machine. Option A2 is, listen, I don't want to be intubated. Do not put that thing down my throat. Comprehensive efforts may include limited ventilatory support by CPAP or BiPAP. So that's support, respiratory support, but does not include the tube down the throat. Okay. And then finally, no CPR, option B, is palliative and supportive care. So prior to the arrest, provide passive oxygen for comfort, control any external bleeding. Prior to the arrest, provide meds for pain relief as needed, but no other medications. Do not intubate or use CPAP or BiPAP. If my heart or lungs stop, do not attempt CPR. Allow death to occur naturally. Does that help?
I think so.
Yeah? No?
Brittany
Oh,
said, yes,
wonderful.
thank you.
Good. So glad.
Any other questions for Joyce? Again, you're welcome to unmute.
Can you hear me?
We can.
Right. My question is, and I did get on a little bit late, so I'm sorry if it was already answered, but if I have a POA for healthcare, is it necessary or needed or recommended to have this filled out as well, or how does that work?
Right. That's a great question. So you have an advance directive, and the
Well,
patient has identified you as their healthcare person, their healthcare agent, right? Okay, so
right, but
you
it has the power to filled in an advance directive.
power of attorney for healthcare? Yeah.
Mm-hmm.
Okay.
Yeah.
So that's a little bit different. That's planning ahead. So this would be a MOLST is different. MOLST is physician orders. So the advance directive is about patient preferences, where the MOLST is actually a physician order that must be followed by all healthcare personnel.
Okay.
So I guess if we took that question a little bit further, um, you might ask yourself, well, can the healthcare agent take this to the next step? And I think the answer to that would be yes, but that would be a question with the physician to discuss. Because the healthcare agent typically only comes into being when that patient no longer can speak on their own behalf or make their own medical decisions.
Right.
Right. So in that instance, then that would be a conversation that the healthcare agent who has the POA talks with the physician.
Okay.
Make sense?
It does.
Okay,
Yes.
good.
So if
Good.
it's already into play, or even if it's not into play yet, because I have two different situations actually, then it would be basically discussed with the physician as to how that would play into, well, which would take preference or whatever. I'll say priority. I'm not coming up with the right word, but
That's okay. That's fine.
Which one would override the other?
Oh, okay. So
one.
that's easy enough. The MOLST. MOLST trumps advance directive because that is the medical order from the physician. Does that help? Or did I confuse you more?
Yeah, it does because it does because that's what I wanted to know. If this so is it required to be completed, or is it something that's not required under whatever regulations, laws, or that we currently have?
Okay, so nothing is required, right? But let's start with the advance directive for a minute. So I'm the patient and I give my daughter medical power of attorney. So I say, if I can't speak on my own behalf, I want my daughter to make these decisions. As long as I'm able to make my own decisions and speak on my own behalf, I can choose to make out a MOLST with a physician. if I can't speak on my own behalf and it's gotten to the point where I have a chronic illness where I am getting sicker and